So if you look at this, we're really asking to rethink the nature of suicide risk. And so the argument is that it really is not about psychiatric diagnosis, that it really is about skill in self-management capacity, regardless of diagnosis, that it really is a trans-theoretical and trans-diagnostic challenge. And that it is a function of the things that you see listed there. It really is a function of emotion dysregulation, predominantly hyperarousal for the 2/3 or more of those individuals that struggle with this problem. It's compounded by early trauma. And so you have post-traumatic stress overlay to a lot of this, and we'll talk about that as we move forward. It's compounded by poor emotional awareness and self-understanding, that there really is a significant difficulty in terms of understanding individual emotional experience. As I'd mentioned earlier, the issue of shame and guilt and confusion in terms of grief, and we'll talk a little bit about that. It's accompanied by punitive self-attributions and this identity disturbance around three really simple identifiable themes that I would encourage you to recognize and track and discuss with people on a regular basis when you're working with suicidal individuals. And I'm going to share those themes with you. That those problems in terms of emotion dysregulation, poor emotional awareness, really generate difficulty tolerating intimacy. And that the dysregulation secondary to the sense of vulnerability makes it really tough to tolerate intimacy. I'm going to talk to you about what we call the suicidal mode, and that as a result gets activated and makes it really tough to connect and deal with people therapeutically. And what's critical is to be able to explain and understand that with someone in order to get a window of opportunity for intervention. As a result, you get people who have a really tough time, and I would argue that the majority have an inability to ask for help among those that are at highest risk. And so the very things that they need to do, they're not able to do because they don't have the skill set to do it. So the easiest way to think about it really is in terms of self-management skills, that self-management skills have been limited in terms of development, and that's something compounded by difficult history. And that we've really focused on developing those skills. And when those skills develop, you get better problem solving rather than this poor problem solving and poor interpersonal functioning, which are ultimately dependent on those self-management skills. If you can't reappraise a context to be able to down-regulate hyperarousal, if you can't do that cognitively, it's really tough to problem solve. And so that's one of the reasons problem-solving therapies had very limited impact. We used to do that very early on and learned that they just weren't ready to engage in problem-solving therapy. And that's, I'll talk a little bit more about why that's probably the case and what we believe is the mechanism of action as a part of this. So really what we would argue is that hope is a skill, and that's a part of the self-management domain. And it really has three identifiable areas. This notion of a cognitive component in terms of this capacity to engage. A big part of it is you have to really create a reservoir of material to be able to engage. That for the majority of individuals that are struggling with suicidality, the majority of the cognitive content really is hopeless based on built-in life experiences that are painful and difficult. And so when asked to reach into that material, ultimately what they have is material that is predominantly hopeless and this trauma and abuse-based material. So I'm going to talk to you a little bit about how we do that. With some really simple interventions that have been surprisingly effective. I would tell you, I actually didn't think they would be as effective when we first started the work, and they've been remarkably effective. They have to build this emotional physiological ability in terms of emotion regulation, distress tolerance, and capacity to self-soothe. That is also a function of just building emotional awareness, self-understanding that's non-punitive. And then what comes along with that, this idea of working on interpersonal skills, building capacity for intimacy. I would argue, if you look at the work that we've done with the military in terms of treating PTSD, about half of those individuals have significant suicidal overlay. One of the things we did was treat the suicidality, develop self-management capacity before doing exposure-based therapy for trauma. And as a result, individuals were much more capable to fully engage in traditional exposure-based treatments like CPT and others for trauma. Because they could self-manage the suicidality adequately before starting that. So I think about those pieces, and the argument really is that if you look at suicide risk and how traditionally we think about suicide risk, we really get distracted in significant ways with symptoms.